So good morning, everyone. I know some of you are still coming on now in the usual 5 minutes after the hour, after the half hour, but welcome to expanded province-wide rounds. This has become a little bit of a habit since April, but we're very excited to actually have Dr. David Collister from McMaster University in Hamilton with us today, and this will be our first virtual rounds with a visiting speaker. So thank you. David was intending to come to Vancouver for a visit in March sometime, but that didn't work out, or April. So, but we're really glad that he was able to join us virtually today. So Dr. David Collister is a nephrologist and a clinical scholar at McMaster University. He's just completing his PhD there in health research methodology. And he's comes from a big Western background, if you will. He went to medical school at the University of Manitoba. He did his residency at the University of Alberta and a nephrology fellowship back at University of Manitoba. But most importantly, and very relevant to us and to the nephrology world, his research interests are those of symptom management in patients with kidney disease, and particularly randomized controlled trials for the treatment of uremic symptoms and hemodialysis. And I think certainly during COVID and other things, our focus on how best to deliver care and treat our patients in the hemodialysis unit has been really important to us. And I think that we're all looking forward to hearing and understanding what's new and how we can study this best. So David, welcome virtually, and thank you very much for making the time. And over to you.
Thanks so much, Adair. All right. Just waiting to get control of the screen. All right. There we go. Okay, so things I'm going to talk about today are a couple symptoms in dialysis, including the diagnosis, measurement, and treatment of restless leg syndrome, which I'm currently doing a trial on, uremic pruritis, depression, and chronic pain. So we're going to go over all of those, and then specifically talk about cannabinoids as a novel intervention for uremic symptoms. Go over a little bit we've done for patients and physician surveys, and then we are planning a pharmacokinetic study and a pilot trial in this area. And then there's the potential for other clinical trials as well. So symptoms in dialysis, this is a systematic review of end-stage renal disease populations. So hemo, PD, transplant, about the point prevalence of all these different symptoms from 2007. And of the four that I talked about in the previous slide, pruritis is about 50%, pain is about 45%, and then restless legs and depression are a little bit lower at 30%. So these are things that we see very commonly when you round in the dialysis unit or see your transplant patients that are very, very frequent and important. And this is relevant because when you look at the illness trajectory of dialysis patients, early on at dialysis initiation, depending on goals of care and comorbidities and prognosis, we really think about our standard dialysis care metrics. So things like blood pressure, vascular access, mineral bone disorder, with a bridge to transplant being a focus in most patients if they're possible. But as things progress or prognosis changes, we kind of relax our metrics and focus on clinical care. And there's a shift towards symptom control and management, addressing a lot of those symptoms I mentioned before. So how does this align with research priorities? So Dr. Mans and Dr. Levin did a priority setting exercise with patients with advanced kidney disease or nearing dialysis or on dialysis, and compared the views of physicians versus family members and patients with disease experiences. And on the left hand of the slide, the physicians, the things, research priorities really align with the traditional quality of care metrics we typically think about, things like adequacy, vascular access, calcium phosphate, PTH control, etc. Whereas patients on the right, 6 out of the top 10 research priorities were actually related to symptoms. So things like pruritis, fatigue, problem sleeping, depression, restless legs, as well as cramping during dialysis, in addition to other things like travel and exercise. So for restless leg syndrome, not everyone might be familiar with this condition. So it affects 5 to 10% of the general population. About 2 to 3% of people have actually clinically significant symptoms. So there's probably people in the audience sitting there right now, tapping their foot or feeling the urge to move their legs. The pathophysiology is multimodal. So there's a central nervous system hypothesis of central iron deficiency and abnormal dopamine pathways. And there's also a thought of genetic predisposition as well as peripheral nervous system neuropathies. There's primary and secondary causes of restless leg syndrome. The one we're most familiar with is CKD and dialysis, but there's other types of neurological conditions as well as iron deficiency in pregnancy that can contribute to it as well. It's important because it's potentially associated with cardiovascular disease and as well as sleep disturbance and poor health-related quality of life. There's screening questions that you can use to try to identify the symptom, but specifically it is a clinical diagnosis from a physician with specific criteria, which I'll go over in a second. And there's patient-reported outcome measures that are mostly used in research settings to quantify disease severity when we study to see if it's effective or not when we trial an intervention. Overall, day-to-day, I think most of us use a patient global impression where we ask a patient, are things getting better or worse? And we might anchor it to a scale. So there are specific diagnostic criteria for restless leg syndrome. The first one, it's an urge to move your legs, which may or may not be accompanied by unpleasant or uncomfortable sensations. And it's kind of a misnomer because restless legs doesn't have to just happen in the legs. It can happen actually anywhere in the body, and it could be spreading towards other body parts. That urge to move the legs or any body part happens at rest or is worse during periods of rest. So when you're sitting down, lying, listening to a presentation, etc., then that urge gets better or is partially improved by movement. So things like walking and stretching, as long as the activity continues. Number 4, that urge happens at night or later on in the evening compared to during the day. This can be different in people that have altered sleep schedules or shift workers. And then lastly, number 5 is one of the most important things, is that spectrum of symptoms cannot be otherwise completely explained by something called an RLS mimicker. So things that are common in dialysis patients like venous stasis, edema, arthritis, leg cramps, other things. Just to mention, there are no specific diagnostic criteria in dialysis that differ from the general population, but it typically involves 4 out of 5 of these criteria with considerations of the last one. So we did some work, I guess 2 years ago, about screening questions for restless legs in dialysis patients. So we took 50 dialysis patients in a single center here and looked at some of the screening questions to try to identify who has restless leg syndrome, with the gold standard being a clinical diagnosis by myself or another physician, going over all those criteria we mentioned before. So a single question from a cohort in a neurology clinic of when you try to relax in the evening or sleep at night, do you ever have any unpleasant restless feelings in your legs that can be relieved by walking or movement, is a really sensitive question with about 86%. The Edmonton Symptom Assessment Scale, which is a single question that just mentions do you have restless legs or not, and doesn't give any information specific to patients what that is, also has a relatively good sensitivity, around 79% at a threshold of 1. And then lastly, if you actually give one of the patient-reported outcome measures called the IRLS, which I'll go over in a second, that one actually has pretty good sensitivity and specificity combined with the highest area under the receiver operating curve of 0.75. So these are decent approaches for screening for restless leg syndrome in dialysis population, but there does need to be confirmation for the clinical diagnosis to rule out mimickers as well. So this is a busy slide. I'm just going to focus on the top left corner. These are all the different types of patient-reported outcome measures we use in clinical trials in this area. The IRLS on the top left is the primary outcome for most trials, and it basically measures different aspects of the disease, about how severe the disease is, how frequently it happens, how much does it affect your sleep and your function, and it ranges from 0 to 40, with higher scores being more severe, and it has a minimally important difference of 3. The other patient-reported outcomes certainly add more burden when you ask patients to fill them out, but do capture other constructs of the disease are important as secondary outcomes. So the ORN has gone out with a symptom management guide for restless leg syndrome that myself and Dr. Michael Walsh from McMaster were involved in creating. It's really adapted from the BC Renal Agency's symptom management guide released several years earlier. But just to go over a quick approach to restless leg syndrome, the diagnosis is very important. So really consider primary versus secondary etiologies. So other things may be contributing other than just being a kidney disease patient. Medications like dopamine antagonists or SSRIs or SNRIs or other stimulants, alcohol, caffeine can be contributing. So making sure you get the diagnosis and contributing factors correctly are important. If symptoms are only happening a couple days per week, L-DOPA, carbidopa, or Cinemet is a good place to start. You can start with half a tab and titrate up over the next couple days. If patients have persistent symptoms, then it's basically a dopamine agonist or alpha-2 delta ligand like gabapentin or pregabalin that can be titrated over the next couple days, watching carefully for tolerability. And when you start to get into more refractory cases, that's when you can start thinking of adjunctive agents or potentially combination therapy, which is the focus of our trial. So one of the challenges about using alpha-2 delta ligands is that there's definitely a risk of harm in the dialysis patient population because they're renal cleared. So this is a study from the USRDS looking at a 1-year follow-up and a time to event model for emerge visits or hospitalizations for altered level of consciousness, falls, and fractures, looking at gabapentin and pregabalin at dose increases used at baseline. So from 0 up to 300 or 0 up to more than 100 for pregabalin. Realizing that most patients in this cohort were using these medications mostly for neuropathic pain, and only about 4% were actually using it for restless leg syndrome in the cohort. Regardless, there's a graded increase of the risk of, or the hazards of altered LC, falls, and fractures with increasing doses of gabapentin. So with titrating up doses, whether it's for any symptom, there's a risk of harm. So that trade-off and tolerability needs to be assessed. So this leads us to the clinical trial we're doing here at McMaster and in 10 sites across Canada, with the thought process being maybe low fixed combination therapy of dopamine agonists and alpha-2 delta ligands can actually improve symptoms without issues about safety or tolerability. So we're looking at adult dialysis patients on hemo at least 3 times per week because under dialysis can contribute to RLS severity with restless leg syndrome by the diagnostic criteria I mentioned before. We do allow for RLS mimickers because certainly in clinical practice, it's challenging to distinguish what's the main driver of someone's symptoms. And we want to be as pragmatic as possible. Patients with mild, moderate, or severe restless legs with an RLS greater than 10 with symptoms more than 2 times per week. Otherwise, they would just probably be on L-DOPA, carbidopa, can participate in the trial. We're excluding anemia, which is something that can contribute to disease severity, and then anyone unlikely to benefit from participating in the trial and at risk of dropout from pregnancy or for safety, and then planned kidney transplant, travel, or relocation over the next 6 months. So the study begins with a placebo run-in period, so 2 placebos that are single blind, so the patients don't know that they're receiving that, but the physicians do, and baseline dopamine agonists and alpha-2 delta ligands are washed out during this time period. Patients that adhere to their medications still have a restless legs severity of mild or greater with a threshold of 10 and tolerate the washout of their baseline medications are then randomized into the trial. So it's a crossover trial with 4 treatment periods, each lasting 4 weeks. So each patient gets to try every single combination of gabapentin and ropinirole, gabapentin and placebo, placebo plus ropinirole, or double placebo for 4 weeks. The efficacy measures are done at the 3 and 4 weeks of each crossover period because there is no washout in between treatment periods, and we justified this based on the pharmacokinetics of both agents. Ropinirole is not renally excreted, and gabapentin's half-life, although it is renally excreted, is dialyzable and should be gone by 1 to 2 weeks post-washout. The primary outcome is an IRLS. We've powered to detect a minimally important difference of 3. We're also comparing in a hierarchical fashion single gabapentin versus single ropinirole versus placebo. And then our secondary outcomes are listed there. So right now we're at 10 sites across Canada that are active. COVID has kind of delayed further recruitment. We have 15 patients, mostly at 3 sites so far, and hoping to get restarted as soon as research opens up again, to be done in the next, hopefully 4 to 6 months after things get going. One of the really cool things about our trial is through its funding through Council of CKD is we've used patient engagements for pretty much every part of its development, from the protocol and intervention selection, patient-reported outcome selection, to really use patients that have restless leg syndrome to inform the design, to make sure that it's suitable for patients, it addresses an important clinical question, and that it's feasible. So beyond that, and using patients to create information materials like the informed consent form and patient information sheets, we've actually created another tool to enhance recruitment at centers, because a lot of patients have exposure to research. They may or may not understand what a crossover trial is, or even what restless leg syndrome is. So this is just an example of one of the pages in this binder that's an enhanced informed consent process that describes the nature of the trial, and it goes through all the standard informations in an informed consent form, just with a lot of pictures and further descriptions that coordinators and physicians can use to recruit patients. We're hoping it can help with recruitment, and that it's one of the novel aspects, and we're studying it as a study within a trial to see if it improves recruitment and retention in the patients that use it. So we think it's a really cool novel idea. So we're going to switch gears to uremic pruritis, which is another top research priority. So this one again affects about 50% of patients with end-stage kidney disease. So the classification of pruritis involves basically 3 different types of groups. So there's pruritis on diseased skin or non-diseased skin, and then as a result of chronic scratch lesions, as a result of having itchy skin. So the differential approach really includes systemic causes like kidney disease, primary dermatologic causes. There's other neurologic, psychogenic, and mixed conditions. So having an approach to the diagnosis, because not all itch in dialysis patients is specifically related to dialysis. There might be other contributing factors that are can be addressed by alternative therapies. So the mechanism of itch in dialysis or advanced kidney disease has multiple factors involved. Centrally, opioid imbalance between different types of receptors is important and is a therapeutic target. Dry skin or xerosis is another contributing factor too. On the right-hand side of the slide here, there's just images of some of the skin changes associated with pruritus that you might see clinically. So things like excoriations or hyperkeratotic nodules, which is prurigo nodularis. That's some pretty dramatic scratch lesions on the picture there that can further exacerbate itch and also cause infection too. Other causes are issues with hormones like parathyroid hormone or calcium and phosphate imbalance, as well as they haven't identified a specific uremic toxin, but certainly cytokines and inflammation are elevated in patients with uremic pruritus. So in DOPS waves 1 to 5, the question that was asked was, during the past 4 weeks, what extent are you bothered by your itchy skin? And this is over the 5 different waves, the most recent one being in 2012 to 2015. So in the systematic review, I mentioned before, the point prevalence was 55%, but the range is about 10 to 77%. And this really depends on how you measure itch and what severity or threshold you use, and localized versus general. And there's different patient populations and ways to do dialysis and comorbidities that may contribute. But in DOPS, it looks over time that the response to this question, that it's pretty stable on the 5 cohorts. And if you look at the patients that are 30% or so are not at all bothered, 30% or so are somewhat, moderate is about 20%. And then when you get into the very much and extreme, it's about 10% for each category. And Canada was one of the centers in this, obviously. So there is variability across the world too, but I won't go into that into detail. So when you measure itch, it's basically a visual analog scale on 0 to 100 millimeters as primary outcome in most trials. There's also things called the verbal rating scale and a numerical rating scale, which is 0 to 10. This just captures the severity of itch. There's other aspects to the disease on the right-hand side besides intensity or severity. There's things like how it affects sleep, coping, quality of life, mood, and affect, and different types of aspects to the disease that these tools don't capture here on the left, but when you look at secondary outcomes, they measure more in detail. If you look in DOPS 1 through 5 for about treatments, for first-line therapy on the right-hand side, topical antihistamines and oral antihistamines or oral antihistamines like over-the-counter or prescription are the first-line therapies mostly, and second-line therapies. And it's when you get into the third-line therapies when you start seeing alpha-2 delta ligands, and then other things like SSRIs or SNRIs or anxiolytics. One of the problems with this area, and this is a systematic review from 2007 from a group in Winnipeg that looked at all the randomized controlled trials that were either placebo or active comparisons, is a lot of the trials are small. They don't use patient-reported outcome measures that have been validated and responsive and reliable. And then they have issues with blinding, selective outcome reporting, and are at moderate risk of bias in some domains. So there's a lot of different treatments with a lot of uncertainty about what actually works. And most of them are crossover trials that are placebo-controlled. The most evidence seems to be for pregabalin and gabapentin, and then some of the topical and oral antihistamines as well. These medications do have side effects that can limit their use and tolerability, as I mentioned before. One of the really good trials that I always like to talk about is the use of emollients. So most of the evidence for emollients in itch are from non-dialysis populations, but this is one of the few studies where it took 200 or so patients and randomized them to glycerol and paraffin in oil and water emulsion and compared it to the placebo, which is just the oil and water emulsion. And each patient was actually given active and placebo on different sides of their bodies and crossed over. So there's some efficiency in doing a crossover trial on the own patient themselves, and looked at the primary outcome of visual analog scale on the right, decreased from about 4 to 10 over 4 weeks and persistently at 56 days. And then other objective measurements of itch and skin changes also improved too. So this is the evidence for emollients in dialysis. So whether you use Cetaphil or a Galaxol base or Uromol cream, these all have some degree of emollient that treats cirrhosis or dry skin and is hydrating to the skin. Some of them have other active components, but I won't go into that. So similar, there's an RN symptom guide for pruritis. The diagnosis is really important to make sure that you know that there's other differentials for itch. Sometimes there's going to be allergic reactions or problems with adequacy or elevated phosphate or skin conditions that can be addressed. The non-pharmacologic measures are really important. So really treating that dry skin and avoiding irritants like harsh soaps and really, really hot water and bathing all the time, and clothing that really scratches is important to provide the prevent infection superimposed. For the generalized itchiness, first-line therapy is gabapentin and pregabalin, which can be limited by dose tolerability, and antihistamines and other options are second, third line. When things start getting refractory, that's when you can start looking into UVB therapy and referral to dermatology, but the evidence for that is relatively scarce. So this new trial came out last year, and it was at Late Breakers at ASN, and it's called CALM-1, which is difelikefalin, it addresses that opioid imbalance in receptors centrally. So this is an IV medication that's given 3 times weekly in dialysis, and this is a multinational RCT that's placebo-controlled in hemodialysis patients with moderate itch. So that visual analog scale had to be 4 or above. And it was powered to detect a 4 decrease in the visual analog scale at 12 weeks with follow-up to 52 weeks. And on the right-hand side, it shows the mean change in the worst itching intensity numerical rating score. Over time, there's clear separation between the groups, with a mean difference between them around 2. There is definitely a placebo response for any type of itch in clinical trials, whether it's dialysis or non-dialysis. And the left-hand side is the outcomes anchored to or dichotomized to a 3 or 4 improvement in scores between groups, which was statistically significant with a p less than 0.01, as well as changes in secondary outcomes that capture all those other aspects of disease other than disease severity. So something called the 5D itch score and the Skindex 10 were significantly different between both groups and above their minimally important difference. So this was a trial in 189 patients in both groups and shows benefit. One of the concerns about it is there's definitely some nausea and vomiting that was more common in the active groups. And the question always is does that lead to unblinding? Because patients know that they're getting an active therapy, which might improve their response to the therapy. And what is tolerability long-term from dropout beyond 12 weeks. At 52 weeks, they did have follow-up, and there was relatively equal amounts in both arms. And one of the big questions is this is an IV medication given during dialysis 3 times a week and the cost. So the company is now working on a oral formulation that's going to be studied soon. So this is a new and exciting therapy that we're going to see what happens, because a lot of the current evidence I went over, as I mentioned before, is relatively poor. And even with effective therapies, residual symptoms of itch that affect quality of life and symptoms are still common. So any new options are very welcomed. So we're going to move on to depression and mood disorders in dialysis. So there's the DSM-5 criteria for major depressive episode that I'm sure everyone is familiar with. So it requires 5 or more symptoms from the SIGI caps. And one of them has to be either depressed mood or anhedonia, and then other ones are the somatic symptoms or psychological symptoms. It has to be affecting function, and the important thing is it can't be the direct result of a physiological effect or a general medical disorder. So one of the challenges is in advanced CKD or dialysis, uremia to some extent, we know causes fatigue. We know it can affect food intake. We know it can affect mood just in general. And on the left-hand side of this slide, there's a lot of stressors that happen in dialysis or any chronic illness that can really contribute to the patient's mood and function. That's in the context of there's cultural components, there's individual personality components, and degree of psychosocial support is important too. So the question always is depression in dialysis different than depression outside of dialysis? What is reversible or not reversible as a symptom or as a psychosomatic symptom? And there's challenges about diagnosing. And interesting, a lot of the measurement tools have really different thresholds that are higher in dialysis than outside of dialysis. If you look at the point prevalence of depression in CKD or dialysis, including transplant, depending on if you use a patient or clinician administered questionnaire or an interview-based assessment, that's really the gold standard going over the DSM criteria. The point prevalence kind of varies with clearly higher prevalence if you use a questionnaire versus a gold standard, but seems to range about 30% down to 20% in an interview-based assessment. Depression itself, regardless of how you diagnose this, is associated with a whole bunch of adverse outcomes in CKD and dialysis. They're all listed here. Most importantly, mortality is increased, but a whole bunch of complications related specifically to dialysis and different modalities and cardiovascular events are all increased. This is just a systematic review going over mortality of all the studies that have reported it previously, and it has a hazard ratio of 1.51. So the question really is this increased risk of depression in dialysis treatable? And similar, should we screen for it if we can have effective treatments that improve symptoms and outcomes similar to the general population? So I'm just going to go over 2 trials that have come over the last couple of years. The CAST trial is a trial in the US, in Texas, of several centers of 193 patients. It's screened for depression using the qualitative inventory for depression scale C16, which ranges from 0 to 27, and a score of 6 or higher is mild disease, and then increasing scores or higher symptoms. The mean baseline in this trial was about 14. It did require a clinician diagnosis of depression. So it randomized to sertraline versus placebo once daily. The sertraline was titrated, the placebo was titrated as well to get to a therapeutic effect based on tolerability, with nausea and vomiting were more higher in the sertraline group without any concerns about QTc prolongation in this trial from a safety perspective. But one of the surprising thing was it's 12 weeks, there was absolutely no difference at all in the change between QIDS C16 between sertraline and placebo in the CKD population. And these secondary outcomes also related to depression and quality of life were not different. The response and remission definitions using the scale were not different. So this really casts some doubt about the efficacy of SSRIs or SNRIs for mood in advanced CKD. And the question really is there something about this disease that's different from the general population depression, where SSRI and SNRIs, based on network meta-analyses, have a really excellent response and remission rates. So questions about that. This was followed by a CBT versus sertraline trial in Annals in 2019. The background for this is the CBT evidence. There's two trials, one from Brazil and one from the States in 2014 by Cucor and Duarte, that showed CBT with different levels of intensity in person in the dialysis unit with specialists trained to do it, do improve outcomes of mood and quality of life and depression. But this trial specifically was not placebo controlled. It was comparing CBT versus sertraline in 120 patients in the US. The tool that they used in this trial was the Beck Depression Inventory, and they used a cutoff of 15. This tool ranges up to 40. Again, higher levels or higher symptoms. And it looked at CBT over 12 weeks versus sertraline titrated up to 200. And its primary outcome was this QIDS-C, as well as a whole bunch of secondary outcomes related to depression, mood, satisfaction, sleep, and physical activity. They did have a kind of a run-in period in this trial where they looked at patients that were eligible and agreeable and had this engagement visit to see how motivated patients were and would they tolerate and be successful with CBT. And then they ultimately randomized 60 to each group with pretty good follow-up. This is a busy table, but it basically shows all the primary and secondary outcomes of the different patient-reported outcome measures. Sertraline seemed to be better than CBT, but a lot of the effect sizes were the 95% upper limit of normal for the confidence interval did seem to cross 1 in a lot of them. And even the ones that didn't, they don't make any comments about the effect size relative to their minimally important differences. This again is not a placebo-controlled trial. I think people believe that CBT generally works in dialysis, and they had some issues with missing data and imputation as well. And the AEs for sertraline were a little bit higher compared to CBT as expected. So given this, it seems that SSRIs are similar to CBT in dialysis, but why would that be true for CKD versus non-CKD is still an outstanding question. So I'll just briefly mention that there's an ORN symptom management guide for depression. The approach that the ORN has really taken is screening, diagnosis are important, and assessing for actual risk and harm behavior, and really finding the person within the circle of care, whether it's a primary care provider, someone within the nephrology team, or an expert in psychiatry to manage this condition that are comfortable taking the lead or referring as appropriate. So lastly, for pain, I'll quickly go through this. Pain is very complex. There's physical and psychological components. It can be acute or chronic, which is a 3-month cutoff. Nociceptive, which is related to tissue damage, or neuropathic, related to nerve issues. Psychological effects, physical functions, experience, goals, and expectations are all really important. Chronic pain is generally cancer versus non-cancer. For the non-cancer components, we think about neuropathic, MSK, inflammatory, and then compressive. The treatment from the general population for nociceptive pain, first line is acetaminophen, which really has very little risk of harm or NSAIDs as well. This is outside of the setting of CKD. And second line being opioids with time trialed to see if it's effective with reevaluation for stopping with their known harms. For neuropathic pain, tricyclic antidepressants and SNRIs or alpha-2 delta ligands are first line. And then, as I mentioned before, opioids are really controversial. There's really insufficient evidence for long-term efficacy and there's known harms. Pain, similar to pruritis, has the visual analog scale, numerical rating scale, and overall descriptors. There's different thresholds for mild, moderate, and severe, which are listed there. One really important thing for pain is to think about physical and emotional function and quality of life as secondary outcomes to see if changes in pain severity actually lead to clinically relevant changes in those disease aspects. The MID for this is 10 millimeters on a 100 millimeter visual analog scale. So pain specifically in dialysis, this is an algorithm from the left that attributes it either to dialysis related, so things like headache, cramps, needling, different types of surgery or medications, and then result of intradialytic hypotension. And then there's non-dialysis related stuff related to all the categories I mentioned before. Some are specific for dialysis conditions like pruritis can be painful, calciphylaxis, and peripheral vascular disease, which is increased in our patient population. Sarah Davison from Edmonton did one of the biggest studies about causes of pain in prevalent dialysis patients in the Northern Alberta Renal Program and showed that MSK is really the big number one, with osteoarthritis and MSK and fractures being the biggest causes. But neuropathy and peripheral vascular disease are also pretty common as well. She then did a scoping review that's been updated, hasn't been published, but the use of analgesics in this patient population, acetaminophen about 26%, NSAIDs surprisingly at 16%, and opioids at 22%. We don't know the prevalence of alpha-2 delta ligands, tricyclic antidepressants, or cannabinoids in advanced CKD dialysis or transplant. There are very, very few studies dedicated to managing pain in dialysis. This is one of the biggest ones that's only a couple, 45 patients that use the World Health Organization pain ladder in end-stage kidney disease that really started with acetaminophen as step one, opioids or tramadol for moderate pain, and then more potent opioids for severe pain. They did use different types of adjuvants like gabapentin. Most patients with neuropathic and nociceptive pain actually got really good, great control. Again, the problem with this is it's not blinded. There's no adequate control group, but the World Health Pain Ladder seems to be effective in this small study. Just for terms of reference for how these medications work outside of the CKD and dialysis population, this is a systematic review that shows acetaminophen works and probably has some degree of improvement, but it's really small. But it's generally worth a try from a pain and function and arthritis, because you can never predict who's going to respond or who isn't going to respond to acetaminophen. NSAIDs, just quickly, there's adverse effects with them that we know as nephrologists from AKI, electrolyte, heart failure with salt and water retention. Unclear if the risk of CKD progression is from AKI or mediated through something else, but generally most trials are limited to a short period and also discussing risk benefit with regards to GI bleeding and cardiovascular disease. Again, there's no trials dedicated to this for safety or efficacy in CKD or dialysis. And then opioids, Jason Busey, who's a nephrologist or a chiropractor and methodologist from here, has shown that opioids really don't have long-term efficacy effects. This is one of 26,000 participants in 96 RCTs that are placebo-controlled, showing that their efficacy for function and pain is really, really small. So this needs to be an individualized decision and needs to be reassessed long-term, because opioids do increase risk of AEs and SAEs long-term. This is another systematic review showing that they're associated with AEs and SAEs, specifically things like nausea, vomiting, dizziness, drowsiness, confusion, stuff like that. In dialysis specifically, this is a similar study to the gabapentin and pregabalin one I mentioned before, using USRDS data, that even lower dose and recommended opioids that we use all the time in dialysis, like hydromorphone, fentanyl, and methadone, increase the risk of falls, altered LOC, and fractures relative to no use. In another study from Kimmel using the same patient population methodology, even short-term opioid prescription versus chronic opioid prescription increases the risk of dialysis and all-cause hospitalization and stopping dialysis. I'm just going to skip over this symptom management for pain, just so that you guys are aware, and it's available in the BC Renal Agency as well. It specifically doesn't mention anything about cannabinoids directly in that one, except at the bottom to consider their use. So there's a systematic review for cannabinoids for pain from JAMA from 2015. Most of the studies are from nabiximols, or Sativex is the other name, which has CBD and THC, which is a spray and has a sublingual approach, versus tetrahydrocannabinol, which is smoked. When it looks at the overall effect size, the odds ratio for having a 30% reduction in pain is 1.41, with a 95% confidence interval of 0.99. So it seems to have a clinical benefit, but one of the issues is always about placebo-controlled, the degree of unblinding with THC, which has psychoactive effects, and then long-term safety and other adverse events, which are well known for THC. These are the adverse events here, this from the same systematic review. And when you look at the individual AEs and high-level MedDRA coding, it's really GI side effects, nervous system side effects, and psychiatric effects. So things like dizziness, nausea, vomiting, diarrhea, confusion are the things patients within clinical trials most commonly complain of related to THC. It can also cause tachycardia, and CBD, there's concerns about intradialytic hypotension and drug-drug interactions. So this leads to cannabinoids in CKD and dialysis. So this is something I'm interested in, and I think there's an opportunity to study, because I think a lot of the symptoms I talked about don't have a lot of options to treat them, and those that do exist have a lot of side effects, are not tolerable, and there's residual symptoms even with effective therapies. And this is in the context of symptom management is really a top research priority for dialysis patients. Cannabis does have a biologic rationale for a lot of the symptoms, and there's some evidence from the general population. Now that cannabis has been legalized in Canada since October of 2018, there seems to be an increase in use and cultural acceptability. Our patients here in Hamilton, and when I was in Winnipeg and Edmonton, were using cannabis for some symptom management and control, but really we don't know if it works and we don't know if it's safe. So my research program is focused on some survey work from physicians and patients, pharmacokinetic study, and then pilot trials ultimately tackling these symptoms. So cannabinoids, the ones we tend to focus on is THC and CBD, which has psychoactive effects and don't have psychoactive effects. These are, they have CB1 and CB2 receptors, which are G protein receptors that are located throughout the body. You can take cannabis a whole bunch of different routes. The most common ones are inhaled, so smoking, vaping, oral, and then transdermal is a new route for pain and pruritis potentially. They're metabolized primarily by the liver in different cytochrome P enzymes. There is some degree of renal clearance with 20 to 35% of their metabolites excreted, but really there's no PK or pharmacodynamic data in dialysis. This is just like the only study of any type of pharmacokinetics in CBD, and it involved 8 patients with a creatinine clearance less than 30, which is at 21.7. It had different ranges of CKD with moderate and mild declines in creatinine clearance, and it showed no difference in Cmax, Tmax, or area under the curve between the 4 different groups in this study. But again, the lowest GFRs were or creatinine clearances were in the 20s, and we don't know about the dialyzability or anything in regards to this. No difference in AEs in these groups. So from their effects in the general population, there are systematic reviews showing potential for benefit in chronic pain, mostly cancer and neuropathic settings. Chemotherapy-induced nausea and vomiting, but it isn't really a standard of care anymore because new effective agents like ondansetron and NK1 antagonists seem to be more effective. MS spasticity, there's some evidence for, and then another new one is seizure disorders in pediatric populations. There's a couple of trials from New England in the last couple of years. And the reasons why there's so diverse indications for this is because CB1 and CB2 receptors, like I mentioned, are located throughout the body. So they're in the central and peripheral nervous systems. From a pruritis perspective, they're in the skin. They're on different immune mediators. They interact with many different pathways and different neurotransmitter systems. So they really have many targets and many effects, but that also means that they have many off-target effects too, and safety and tolerability is a big issue. Given their renal clearance too, we need to be very careful about using this in our patients and studying them. So this is a survey we did last year, and it was going to be presented at the CSN this year in a poster format, and it's under revision right now at a journal. We asked 151, which is 43.4% response rate of CSN members that are adult nephrologists. 4 out of 5 of them said that they had clinical experience with medicinal cannabinoids, so they had taken care of patients that were on some type of cannabinoid. The most reasons they were used were for chronic pain and appetite stimulation. 1 out of 5 respondents actually had prescribed cannabis specifically for chronic pain or appetite stimulation. And then 9 out of 10 reported that they had patients that reported to them using non-prescription cannabis. The most common reason was for recreational use, but then across a wide variety of symptoms outside of chronic pain and appetite, they were used as well. We were interested to see what support there was for trialing cannabis in patients if they had refractory symptoms, or the possibility of enrolling a patient in a randomized controlled trial that's placebo controlled across the different symptoms and use multilinear regression to look at independent predictors. So the 2 panels on the right hand side, basically there seems to be most support for all of the symptoms, ranging from means of 5 up to just below 7. The biggest ones are for basically appetite, nausea, vomiting, and pain, with fatigue and depression having the least amount of support. And then for participating in RCT, it's a very similar spread with the support across different symptoms. For independent predictors, we wanted to see if different patient or different physician factors were predictable. And the only one was basically location. I personally thought that BC physicians were going to be more likely to support their use, but Ontario actually had the most degree of support compared to anywhere else in the Canada. I think it's because not a lot of BC nephrologists actually filled this out. Other things like sex, gender, personal use did not independently predict support for clinical trials or in clinical use. We're doing a patient survey too that's going to be spread online as well as in person through the registry for patients considering research in kidney disease. So we'll have those results hopefully within the next year. So because cannabis has not really been studied in advanced CKD or dialysis, we're doing a single dose pharmacokinetic study. So we have funding from the Center for Cannabis or Medicinal Cannabis Research here in Hamilton to do a PK study and a pilot trial. So we're doing one of 10 patients, so 5 men and 5 women that are hemodialysis patients that haven't recently used cannabis and don't have any comorbidities that could lead to safety issues. And we're doing a single dose of oral and topical CBD THC combination that we're planning to use in our pilot trial for uremic pruritis. So it's a 4-week washout in between. So patients come into their dialysis treatment 4 hours early. They are given the agent. Then we measure levels of blood and dialysate and urine cannabinoids over the intradialytic period with a sampling there. And they're going to be quantified using capillary electrophoresis mass spec to see their degree of dialyzability, half-life, and Cmax, to see what type of doses those are. And it's a really big challenge on choosing the dose. I think CBD, most studies use ranges of 5 milligrams per 20 milligrams per kilogram. Seems to be pretty safely tolerated, but THC, we're picking a really low dose of 0.15 mg per kg, just because we're concerned about safety and the risk of unblinding in our trials. So the one trial we're going to do for the first one is a pilot trial of called Dialysis Symptom Control. So same as our restless leg trial, that's a crossover trial, but this one's for pruritis outcome trial is the name. So it involves dialysis patients with moderate to severe pruritis and using a visual analog scale of 50 without any contraindications to the trial or really obvious causes of having itch that isn't uremic pruritis. And they're going to have a run-in period where they're going to get open label of the agent for 4 weeks with titrating increase for safety and tolerability for a dose finding. And then after a washout, they're going to be randomized to combinations of oral and topical together, oral with topical placebo, and then topical placebo plus oral. So each patient gets to try each combination. And this is called an N of 1 trial. So it's really a personalized trial where all patients get to try every single active agent and decide within the context of the trial if there's a clear winner within each treatment period. So if a patient does the first treatment sequence of A, B, and C, and one treatment is clearly better than the other, then they can actually stop the trial and add overall population treatment effects to the total trial, but also individually make a decision that's best for them within the context of the trial. If they don't have a clear winner, then they can extend to the next treatment period and be randomized to different treatment sequence over time. And then we're measuring our primary and secondary outcomes again at the end of each crossover. And there is a washout period between treatment periods for this one. And the big question is what is the half-life in dialysis, and is that washout period going to be long enough, or is it too long and there's carryover effects that we need to switch to a parallel RCT? So our PK study will give us some information about that. So there's just the schedule of follow-up there. Stay tuned once we're finished our restless leg trial and our pharmacokinetic study, which we have a research license for, and we're waiting for the no objection letter, but COVID seems to have stalled a whole bunch of non-COVID related research from Health Canada's perspective, that finishing this pilot trial and then potentially doing the full trial, depending on feasibility, will be the goal. But ultimately, I'm interested in studying all these symptoms with cannabinoids, really being cognizant about their safety throughout this whole process. So based on physician perspective, I think chronic pain and nausea, vomiting, and appetite are really good options to really pursue next, and our research patient priorities. There's actually a trial right now in Israel that's going after appetite, but these other ones too are potential ones too. So at that point, I'll take a break and open it up for questions.
Great, thanks for a very comprehensive and good overview, not just of the symptoms, but also of the pathophysiology of the symptoms that so many of our patients have. And I think it's nice to see the BC Renal various algorithms adopted and adapted in Ontario for sure. So thanks. Any questions from the group? You can unmute yourself to ask one if you want. I guess I'll start with the enrollment for the cannabis trial. Is it started yet, the pharmacokinetic one?
No, we're waiting on the no objection letter from Health Canada.
And the patients, if I understand correctly, were quite happy or excited to be able to have a novel therapy. Is that correct?
Yeah, for sure. Like when I'm recruiting locally for our trials for restless leg syndrome, like I plant what my research program is, what the next target is, and patients are definitely interested and excited to participate in that trial more than one of restless legs for therapies that they may or may not already be on. So like there's definitely a lot of excitement from a patient perspective. And one thing I forgot to mention too is like we've also used patient partners for design of the pruritis trial in a similar way that we did for the restless leg syndrome too. So I'm using patients to spread the word and help with recruitment is going to be a goal for the next one too.
Great. I know it's hard on Zoom for people to ask lots of questions. It's not hard, but it's sort of more awkward because there's so many.
I see one in the question and answer that maybe I can read out loud.
Yeah, that's the comparison between the ORA and symptom management and the BC Renal symptom management guides. Are they, when you looked at them, did they compare as in very congruent, mostly congruent? Do you recall?
So like the BC Renal Agency really were a starting point for this RN symptom guide, and because they were a couple years old, a lot of the things they were updated, and a lot of the evidence, like I worked on 3 of them specifically for like depression, restless legs, and pruritis, and I didn't have to change a lot of the background work in between. And it's pretty easy when there's very few trials or things that update in the interim. So it wasn't redesigning them. So they were very similar.
I guess, are you in clinical practice using the same kind of symptom assessment as you are using in clinical trials? Because I think one of the things that I think people struggle with is we have trials to assess symptomatology, but then in real life, you basically walk around and ask questions or not. And so any understanding of patient acceptance of more systematic asking of questions in clinical practice?
Yeah, so in Hamilton and Ontario, there is routine administration every couple months of the Edmonton symptom assessment, but only about like 50 to 60% of patients actually fill it out routinely. And this is a 10-question tool that takes about a couple minutes. So if you start looking at filling out specific ones for each symptoms and even try to explain what their value is clinically, it's really hard to get buy-in. And I think a lot of us rely on a global impression, whether it's from a patient or clinician perspective. But those ones are used in clinical trials. They do have psychometric properties, but it's a balance between time and use of a valid instrument. So it really depends on the clinician and the level of engagement of the individual. We rely on ESAS here mostly, and then a global impression.
As we do in BC, I think most of the units are using ESAS or have had certainly a lot of experience with regular. Anybody else have questions for David? Appreciating we're just coming to the bottom of the hour. Okay, well, you got at the highest point we had over 50 people on the call on the Zoom, so that's better than we ever get for province-wide rounds for general nephrology topics. So that's a great first.
Good to hear. Yeah.
Yep. So thank you very much for A, making the time, B, preparing everything. Oh, there's one more chat thing here. 1 second. Oh, people just actually congratulating you on an excellent presentation. Thanks, Selena. And appreciating that that everyone, we're going to go to work and go to our clinics and stuff this morning. It's 8:30 here. It's 11:30 there. But again, thank you for giving us a very holistic and detailed approach to both symptoms and potential treatments, as well as a methodological approach to actually figuring out the answers. So we look forward to the results of the trial, and where we can participate, we will. So thanks very much, David.
Great, thanks so much, dear.
For participating.